Hey everyone, I'm excited to be back for our next episode of Connections. I'm Sara Howe, one of the co-hosts of Connections, and today we have a very exciting episode. We have part 2 with Nate Metz and Doc Henry. And why did we do a part 2 with them? So in season 1, you had the opportunity to meet them, 2 professionals from Lafayette, Indiana, not even in the state of North Carolina. So why did we bring them back for part 2? Well, if you haven't listened to part 1, first of all, you got to do that. Secondly, this conversation was so compelling, so exciting that we didn't want to stop. And we wound up rearranging everything while we were at our spring conference to bring Nate and Doc back for a part 2. And I got to tell you, we might have to have a part 3 in the future. You tell us, you can take a listen to this episode and you tell us if you think we should bring them back for part 3. I hope you enjoy it. Welcome to Connections, the podcast from addiction professionals of North Carolina, where we explore the nuances of addiction and mental health through the lens of policy and practice.
We're your hosts,
Sara Howe
and Morgan Coiner, and we're here to help you see how it all connects.
So we've got 2 firsts today. We're coming live from the APNC Spring Conference with a live audience and our first 2-part podcast. So first of all, welcome. We've got 2 guests for part 2 because part 1, we just had too much going on. So we had to do part 2 because, we didn't have that ability to do the outtake. So you guys had to come back. So we are super excited, especially for our audience members. We have Nate Metz and I can't do that, Nate. I don't know why. Nate Metz, it's the Yankee fan of me that's having a challenge. Nate Metz and Doc Henry from Phoenix Paramedic Solutions in Lafayette, Indiana. So we are reaching beyond our North Carolina borders to talk to some of our friends in the Midwest. So welcome.
Yeah, thanks for having us.
Thank you.
And thanks for coming back. We're super excited.
Scare you away.
Yeah, we didn't scare you from episode 1. So for those of you who have not yet had that opportunity to hear episode 1, tell us a little bit about who you are and how you wound up here.
Yeah, so I'll give you the 50,000-foot version, right? I'm a paramedic by trade, also a community health worker. Decided to start an organization called Phoenix Paramedic Solutions. We started out as an ambulance provider, a traditional EMS ambulance provider. We were doing 911 services. I did that for a very, very long time, part of my career. And going through your career for so long and continuously seeing that healthcare systems kind of continuously go down this pathway without adverting their policies and their practices to fit the needs of their communities was something that was very frustrating to me as a provider. So whenever we started Phoenix, we decided that we were going to specifically place ourselves and our programming and our organization in contrast to that kind of action. And we were going to essentially create programs for our community, regardless of kind of how we were going to do it in some fashions. We were just saying we were going to do this regardless because it's what our community needed. And we were going to do it for as long as we could. And Phoenix was kind of born. And then from that, I like we talked about in part 1, we can't even really list all of the different programs and the things that we do in our community. But if we talked to people and we told people we were an ambulance provider and then we told them all of our projects and our programs, I'm not sure if people would connect the two and think that the two are the same.
Mm-hmm. So your organization now, like what would you refer to it as?
Yeah, that's a good one. I'm not really sure.
Oh, we stumped him.
Y'all do not understand the victory that I just stumped Nate. This has never happened.
Right.
I wouldn't define our organization by anything other than our mission. Mm-hmm. Our mission is to break barriers, defy tradition bias, and make absolutely no exceptions when it comes to compassionately providing care to those in need. Everything we do in our organization is about that. Our ambulance provider, now we're also addiction services provider. We just purchased a MAC clinic not a couple months ago. All of these things are just tools to give our community and the people that we're trying to serve what they need. And we'll continue to do that. If it means us becoming we actually just talked about this, right? Because we feed a lot of people during the summer. We talked about becoming a food service provider so that we could do it in more areas and more capacities, right? And so We have 2 people right now that are training to be CrossFit instructors and pound instructors, so we can start doing physical fitness courses within our peer programs and our peer groups. I just got recently certified to do art therapy. The list goes on and on and on and on.
Sounds like you're community servants.
Yeah, absolutely.
So Doc, tell us a little bit how you came to this work.
So it's a long story, but I'll give you the very, very short version of it. I am a person in long-term recovery. I found my passion while working at a recovery residence in Lafayette, Indiana, and I actually knew Nate and his team. I was really restricted by the governing rules of the recovery residence of, no MAT, there's only one pathway, and that's the only pathway, and it didn't sit well with me. My brothers and sisters out there were still dying, and I wanted to do more. And I knew Nate and I knew his team, and they had this movement going, the peer movement. And I've been a peer since 2016, so I've been in the peer field for quite a while. But I had left that recovery residence and hired on his staff there, and I came as an entry-level peer and started working my way up the ranks pretty quickly. I became assistant director of our quick response team and then director of the response team there. And actually, that's where I met you, Sarah. I met you through Third Horizon. You guys were doing a site visit for the state of Indiana, and I had the pleasure of meeting you and your team there. And, it's been insane since then. We haven't looked back. Nate gave the 50,000-foot view of what we do there. But, it's deeper than that, right? We have so many programs going, but it's all community-based. Our mission statement, as he said, rings true. I don't like using the word servant leader because it's thrown around quite often. We actually did a breakout session yesterday on that. And, what we're trying to do is help our community, period.
Well, I think what's interesting is as we talk to individuals here in North Carolina, in any state really, state funding gets siloed, right? And sometimes it's for the current drug today, the opioid epidemic, the methamphetamine epidemic, whatever we're talking about, right? But you all have managed to navigate both, I think, private and public partnerships within a community and figure out what that community needs while not chasing necessarily whatever the shiny object is today, but really listening to the community. So talk more about that.
Yeah, and that's not something that just Phoenix does in a silo. We are incredibly ingrained in our community with our partnerships, and that's something we've always worked for. Every program we've ever done, even with our branding with our QRT, it was never Phoenix branding. It was always community-based branding that everybody could get behind so that we would help break down that competition and those silos between organizations within our community. And from that, one of the processes that we started doing really early on was basically a gap analysis in our community where, we would use a world-class university across the street, Purdue University, and they'd come in and they'd help us.
Boiler up,
boilers,
gotta, had to.
And they would help us map the journey of individuals in our community all the way through the system to finality or recovery. And every time we would do that, we would identify gaps that occurred. Those gaps could be missing resources. Those gaps could be poor transitions between organizations and care. And every time we found a gap, Phoenix would build a program to fill it. Every single time. And we went about it that way. It wasn't about this is a grant, then build a program. It was this is what our community needs. Now let's go try to find a way to make it sustainable or to fill it or to pass it on. And we went after the mission ferociously for what our community needed rather than the pigeonholing that you often see with a lot of the funding sources. So if we were going to do a program and we believe in wraparound services and there's opioid funds, well, then we're also going to need mental health funds and other addiction funds and all the wraparound services funds and other partners to help fill in that gap because we decided as an organization that care for a human being, it couldn't be one-dimensional if we were going to be successful. And we have been successful. I mean, one of our programs that we've been running for the longest, we've had over 10,000 patients.
Wow.
Not a single patient has overdosed since they've been enrolled in our program. 10,000 patients, not one has overdosed. Not one. Now, the resources in that program funding is pretty restricted, but we backfill it with a bunch of other resources and finances and support services, and we connect with other interesting things in communities, right? We have connections with bars. Hope this doesn't make anybody blush, okay? But one of our referral sources is a local strip club. Okay, that was a place we went into and started building relationships with. We're building programs with local barber shops and to turn barbers into peers so that we can get referrals from those areas. So it was really about how do we make this a community effort and an event.
And I think in going to the places in the community that these people are, right? We can be involved in a community, but if the only place you're going to is the church on Sunday, you might not find everybody there, right? So it seems like you've made a really concerted effort to be where the people are.
We're ingrained in that community, right?
Yeah.
So we're actually on site, like with our local homeless shelter, LTHC. We have an office in there. We're ingrained in community corrections. We have an office in there. We're ingrained in the jails in several counties. So we work out of 9 counties as well. Very small team, big impact, right? The work that our team does out there is nothing short than amazing, and they're leading the movement in Indiana there. People are trying to mimic what we're doing at our company. And sometimes we don't even know how we're doing that, right? We're building that data now because sometimes we're building that plane in the air. That's what we like to say there. We have a project in front of us. Okay, what are we doing with this project? And we try to let the employees lead some of these projects. We try to let them build our policies, our procedures, because let's learn together, right? And we're talking about sustainability for peers out there, right? We're not only building just peer-based models, but we're building life skills, right? Because that's something you can put on your resume. Let's say that the peer movement stops all of a sudden. God forbid that, but let's say it does, right? Because it's not sustainable yet, and hopefully we'll get there. But let's say it does. What we're doing is we're building those soft and hard skills for them to better themselves in the future. That's something you put on your resume. I helped build this policy and procedure for this multi-million-dollar program we're running. How amazing is that?
So one of the things you said when I met you all, you may or may not remember this, almost 2 years ago now, is that you had this unique position in the community. Because at the time when I met you all, you were known as the ambulance provider. And I remember both of you and your team saying, we had this unique niche where we could go into the community. We weren't known as the treatment provider. We weren't known as the OTP provider. Now, fast forward 1.5 years, 2 years later, you've got a MAT clinic. I want to talk a little bit about your crisis unit before we close. You've started to do all these different things. So how has your identity evolved in the community?
We're problem solvers. That's how the community sees us now. They see us as just a group of individuals that are going to solve the most complicated problems in our community quickly. And that's what we made a reputation for. Individuals and other organizations come to us now because of the bureaucracy they're up against, because they're in large organizations, or because they're part of government entities, and they see the problem. But because they're in such a structured system, and a lot of that structure is not necessarily rules and regulations. A lot of it is cognitive bias that's associated with how we've always done things. Or my favorite, which is risk aversion-based decisions, where instead of making decisions for what's best for the client, we make it for what's best for the liability or the potential liability of the provider, and then the patient suffers. And we don't do that. And so we have people now who come to us to solve complicated problems because they know we'll do it and we'll do it fast. So now the community looks at us as just overall problem solvers. We get the most complicated patients, we get the most complicated problems in our community.
So it's twofold, right? So we'll be presented with a problem, and it's usually been marked or messed up or ran into the ground by several different entities, not out of spite or anything. It's just out of lack of knowledge or know-how. So sometimes we'll get a broken program, and I don't know what kind of verbiage you would like to use there, but sometimes we'll get a broken program, and it's like a puzzle piece missing a bunch of pieces. But nonetheless, we're going to put this puzzle together, and we're going to make it look good as we can anyways. But we know that there's going to be a lot of work behind it. So typically the answer is yes. Can you guys do it? Sure.
Yep. So I want to talk a little bit about crisis, because we're seeing every state in North Carolina is not alone here, right? How do we manage crisis? And we're seeing so much more need, right, between youth, adults, coming out of the pandemic. That there's so many different things, and you all obviously saw this need, and you're standing up a crisis unit right now as we speak, from North Carolina as we speak, right? Yeah.
So it's kind of interesting. We actually started developing our crisis model in our community with partners 4.5 years ago, 5 years ago, before even really the 988 deployment models were let out and the monies were there. We started developing what this was going to look like. It's actually funny because the program flow chart for the way this program operates, if you look at the data it was created, it was 5 years ago, and we're still using it today. And so we have developed that. And because we were starting the development of it so early, because it was based off of what the community's needs were, our program looks significantly different than a lot of the other programs that exist in our state right now. And there's a couple crisis stabilization units, not many. Obviously, there's a lot more coming because our state's just released funding for it. But we have a subacute care model for our crisis stabilization unit. And I work a lot with the state, obviously, in developing these programs and helping flesh out what this looks like in our state. And how does this integrate with the 988 response model? And how do we pay for this? All this good stuff. And what I found was that if you're an organization that's trying to build a crisis stabilization unit, you have got to get a first responder on your team to help you build this program. The crisis response model is a first responder program. That's what it is. I'm hearing people try to struggle to get through a lot of these challenges that are associated with this. And this is something that your EMS system has been doing for 50 years. You have to remember, the EMS system has already been responding to these people in a lot of cases, and the first responders. Now, be it responding, I think, in an inappropriate way that doesn't help people get to where they need to be. Mm-hmm. But the deployment model is very relevant. And so that's what we've relied on whenever we built our crisis stabilization unit. The other thing that we did is, so in our state, crisis stabilization units and mobile crisis teams have to have a peer component. But that's really the only part that has to be there. We immediately said, nope, this is a community paramedicine and mobile integrated healthcare model. And so we've paired them with community health workers and community EMTs, and we've integrated a subacute care model. The reason why we did that was because we've identified that transitions of care is where most of our overdose deaths are happening in our community. People who are overdosing and dying in our community and our opioid fatality review team, a lot of them were connected with a care provider just 72 hours before. And what we find was that there was no smooth transition between facilities, particularly our emergency rooms, to behavioral health areas or detox centers. We saw a lot of risk-averse behavior where, okay, my client is, they're too sick and too dangerous to be in my facility. But then they discharge them to no one. Mm-hmm. And I'm just like, why are you doing that? How can you make that risk-averse decision? So we said, okay, well, if we're going to do this, not only are we going to have to be able to do this response, but we're going to have to be able to manage these individuals medically, because letting them go out onto the street in these conditions is a non-starter. Mm-hmm. And also, we wanted to create a pathway for direct referral, because people sitting in the emergency rooms, once they're in there for a certain amount of time, if you had them committed to treatment, they're not going now. Mm-hmm. One of our care providers in our community, I was shocked by this, and this is whenever we part of the reason why we designed our program the way we did. They were a detox center. And they stated that whenever they send individuals to the emergency room for medical clearance, they only get their patient back 5% of the time. Cool. So we're like, well, that system's not working. Mm-hmm. And now that means, well, we need to do medical clearance. And so it took me 2.5 years working with our behavioral health providers, because everybody seems to be so non-committal on what medical clearance looks like for their facility. Whenever I hear a facility say, oh, it's a case-by-case basis, I just roll my eyes. And I'm like, okay, well, that means you're leaving excuses for people to not accept patients at 3 a.m. whenever they don't want more patients. Mm-hmm. And I'm not going to hide those comments, because we need to talk about those parts of our system. Mm-hmm. Parts of our system are hurting people, and we hide from that. And we shouldn't hide from those things. We should talk about it bluntly, which I do very frequently.
You see why we're on a part 2, by the way.
For sure.
But so that's why we integrated medical clearance protocols within our crisis stabilization unit, where we can do all the lab draws you need. We can do point of care blood testing. We do all of your UDSs on site. And we can even do frontline stabilization and medical stabilization in the field, and go directly from the field into a behavioral health center or into a detox center.
So when people talk about crisis stabilization units, it's a broad term, right? I'm ingrained over there. That's where I work. That's my primary profession right now. I'm directing these beautiful peers over there. We get called out to some of the worst, if I may. The police department doesn't know what to do. Doctors, therapists, et cetera, et cetera. So it's not like we're meeting these individuals on their best day. With these protocols into place, we're able to medically stabilize them. And not only are we able to medically stabilize them, we can bring in a therapist directly on our unit, right? And that's important, because we want full wraparound services. Peers are amazing, but they're also not able to diagnose either. Right. And that delineation needs to be understood out there in the peer movement, because sometimes peers out there forget that we're not therapists.
Yeah. Right. Right.
But we get called into the community from some of the most severe of the severe. We have no wrong door policy. We're open 24 hours a day, and it's manned 24 hours a day by a peer, an EMT, and a paramedic. And it's important to know the differences between an EMT and a paramedic. And, you know, there's a BLS provider and an ALS provider. Paramedics are able to do mostly what a doctor can do. EMT, they give basic life support, right? They can still stabilize the patient. We can do vitals on them. We can do all those things.
Well, yeah, let me clarify one part, because that's an interesting thing in Indiana. And I'm not familiar with the rules in North Carolina, but something that's interesting with EMS in Indiana, which is part of the reason why I like being an ambulance provider, is there is only a floor for the scope of care for paramedics in the state of Indiana. And so there is no ceiling. So the ceiling is whatever the medical director says that they're comfortable with them doing. Now, does that mean that I think a paramedic should be doing all kinds of, you know, I don't know. I was going to say a couple of things, but there's agencies that are doing that. Right? We have agencies hanging blood. We have agencies putting chest tubes out in the field, cut down sutures, all that kind of stuff. But at the end of the day, the amount of flexibility that exists with creating care models within that arena makes it very easy to pursue new ways to care for people. Now, reimbursement is a totally different issue, but to explore new care models, it's really, really flexible in our state. And the other thing about our state with engaging with your EMS agency is that we are the largest group of healthcare professionals in our state. And I bet you that's the way it is here in North Carolina as well.
Probably, yeah.
And you're probably also, if you would identify, the only healthcare asset that is probably guaranteed to be in every single community and county in this state is probably going to be your EMS agencies. Same with Indiana.
Good point.
And in your rural communities, your EMS agencies are probably only engaged in care 16 to 20% of their entire shift. And so what are you doing with the rest of their 80% of their time to help soften the blow of healthcare shortage in your community? So engage them in a public health capacity or in addictions capacity, and you have a new ally that has time on their hand and a lot of flexible skill sets to help you.
I feel like that is like the perfect entrance for a part 3.
I know. I'm like, I have part
One
3.
downside to doing this live is like we have such a tight schedule, and I want to make sure that we respect everybody's time to be able to get to their next session. But y'all set it up perfectly.
Well, thank you for coming from Indiana, taking some time out from the Midwest to join us here in the mountains this week, and for sharing your knowledge with us.
Welcome.
Thank you so
Very
much.
welcome.
So that conversation was fantastic with Nate and Doc. I'm so excited that you were able to hear it. A couple of things that I took away from that. One is being vigilant to your mission, rapidly vigilant to your mission, which at the end of the day is what drives us in the work that we do. So to hear Nate talk about their evolution as a paramedics team to a recovery organization to treatment, crisis intervention, and at the end of the day, not defining it but anything but their mission. That's a great lesson for all of us. I'm super excited about that. But also, those tough conversations. Nate talked about our field and how we have to sometimes have tough conversations and how we need to question things that might not fit in this field. And so I'm so thrilled to have them. Again, we may have to bring them back because they continue to evolve and they continue to challenge us. And I'm just grateful that you were able to hear them and that they were able to join us. See you next time.